Assalamualaikum doctor. In this video I am discussing about nephrotic syndrome. So nephrotic syndrome is very important. It comes on history, it comes on video station, it comes on communication and clinical abdomen station it comes. So nephrotic syndrome very important. Normally nephrotic syndrome we know the features that is swelling whole body will find that is periorbital swelling and generalized edema present. The differential diagnosis we keep nephrotic syndrome, anaphylaxis, angioneuritic edema, nutritional, cardiac or hepatic. Recently they tell the differential diagnosis, then the examiner take angioneuritic edema in the viva. So we have some idea about the differential diagnosis management. First of all, I am telling the differentiation between nephrotic syndrome, anaphylaxis and angioneuritic edema. Nephrotic syndrome there is pitting edema, where anaphylaxis there is non-pitting and angioneuritic edema non-pitting edema, painless non-pitting non-erythematous edema. Nephrotic syndrome there is negative family history, where anaphylaxis positive history of atopy and angioneuritic edema is an autosomal dominant condition and positive family history. Nephrotic syndrome pruritic, non-pruritic, where anaphylaxis is pruritic and angioneuritic edema is non-pruritic. Nephrotic syndromia, if hypovolemia present then abdominal pain present. Anaphylaxis there is no abdominal pain but airway affection. Angioneuritic edema with abdominal pain. Then nephrotic anaphylaxis investigation we are doing histamine, mast cell tip test, immunoglobulin E. Angioneuritic edema the investigation we are doing C1 esterase inhibitor deficiency, C2 esterase where C2 is decreased during the attack and normal in between the attack, C4 decreased during and in between the attack. Treatment of nephrotic syndrome is oral steroid, anaphylaxis is IM adrenaline and angioneuritic edema is recombinant C1 esterase inhibitor plus anabolic steroid. So angioneuritic edema I am telling especially the investigation and treatment because it recently they asked. Investigation for angioneuritic edema is C1 esterase inhibitor deficiency, C2 that is decreased during the attack and normal in between the attack, C4 decreased during and in between both attack it decreased. And treatment of angioneuritic edema is recombinant C1 esterase inhibitor plus anabolic steroid. Now I am going to history. Suppose it is a nephrotic syndrome, what history we ask? First onset course and duration, first time or recurrent occur. If not in the video, ask any other swelling of the body. So there is any other swelling in other parts of the body. Swelling in the private if boys, and is it itchy, painful, red, pitting or not? Any marks or of socks? So pitting edema is very important. Then what about his urine? Is it frothy? That means proteinuria. The urine is frothy. Any change in its color and amount? So we know nephrotic syndrome there is reduced the amount and also proteinuria frothy urine present. Then anyone measure his weight and blood pressure recently, very important. Any preceding infection, allergy, eczema, food allergy. Preceding infection causes nephrotic syndrome, sometimes viral infections. Any family history of similar conditions, any abdominal pain, has any seasonal variations. Then any shortness of breath, chest pain, fainting, any headache. So shortness of breath, we know pleural effusion, one of the complications of nephrotic syndrome. Any medications he is using, especially steroid. Any chronic condition he is suffering, taking any medications for nephrotic syndrome. And vaccination status and previous exposure to chicken pox. That is very important. So these are the history we ask in nephrotic syndrome station. What examination we do? The examination we are doing, airway breathing circulations, vitals, especially the blood pressure. Then he measures his weight daily, urine output daily and amount of fluid in and out, hydration status for signs of hypovolemia. So remember nephrotic syndrome, all video station we are telling ABC vitals, nephrotic syndrome especially blood pressure, weight daily, urine output daily, amount of fluid he take, water input output chart that is we maintain, and hydration status because of sign of hypovolemia. Other examination we are doing, examination the edema for pitting, eye examination for any infections, abdomen examination for ascites and scrotum for edema, chest examination for pleural effusions and cardiac examination for pericardial effusions. So these are the examination we are doing. Now I am going for the investigations. Investigation, so it is nephrotic urinary system related. First we are doing urinalysis. Urinalysis, that is early morning urine protein creatinine ratio. First morning after admissions, normal value is less than 20 mg millimole, where in nephrotic 200, more than 200 millimole. That is early morning protein creatinine ratio we are doing, usually more than 600 mg per millimole. Low urine sodium less than 10 millimole suggestive of hypovolemia. Remember, less than 10 millimole sodium in urine suggests hypovolemia. Baseline blood test we are doing like urea and electrolyte and creatinine, albumin, full blood count, cholesterol and triglyceride. These are high cholesterol, triglyceride. Immunoglobulin G is low, AM, or doing complement C3, C4. Normally complement C3, C4 is normal, but if it is decreased, then we refer nephrology. It is one of the indication of nephrology. Zoster immunostatus as well as baseline, hepatitis B and hepatitis C serology. Some second line test we are doing when we do request only if featured suggestive of more aggressive nephritis like hypertension, macroscopic hematuria, high creatinine, no response to corticosteroids, then anti-streptolysin O titer, anti-DNase B, anti-nuclear antibody, anti-double standard DNA antibody. Minimal change disease 95% is the most common type. Remember, minimal change disease is 95% if they ask us. So, how can we know evidence of hypovolemia and its management? So, hypovolemia we clinically think when there is abdominal pain, vomiting, looks unwell, poor peripheral perfusion and capillary refill time is more than 2 seconds. Pulse character is steady, low volume, difficult to palpate, tachycardia, hypertension may be an early sign, hypotension a late sign, jugulovenous pressure is low. Lab we find the urinary sodium less than 10 millimole. Remember, urinary sodium 10 millimole. High hematocrit, thrombophilia, raised creatinine or urea. So abdominal pain, hypovolemia, abdominal pain, tachycardia, vomiting, fast hypertension, then hypotension, and urinary sodium less than 10 millimole, we are thinking hypovolemia. What is the management? I will involve my senior advice before volume resuscitations. So I will involve my senior and I give the 0.9% sodium chloride 10 ml per kg. Remember 10 ml per kg. Start dipyridamole and 4.5% albumin. This is the treatment. What is the treatment? I will seek medical advice from my senior. Give sodium chloride 0.9% sodium chloride 10 millimole 10 ml per kg 10 ml per kg and start dipyridamole 4.5% albumin. This is if severe dipyridamole to reduce the risk of thrombotic complication. Discuss need for heparin warfarin with the pediatric nephrologist. So warfarin heparin is severe condition with consult with the nephrologist. Now how can we manage a nephrotic syndrome patient? First of all, we are admit the child. I will admit my child, seek medical advice from my senior AFNet consultant. Okay, as usual. Strict the fluid balance monitoring. So intake output chart I maintain, daily weight maintaining. Avoid the added salt, but a low salt diet not indicated. Just added salt will be avoided. Treatment of hypovolemia if present. Already I tell you hypovolemia features and management and fluid restriction. So this is very important. Fluid restriction, input output chart maintain, weight maintain. There is I will maintain the fluid, avoid extra salt, but not normal diet he can take, and treatment of hypovolemia present. Then going for medication. So you all know that steroid, prednisolone 60 mg per meter square oral once daily, maximum 80 mg per day. So remember 60 mg per meter square in the morning. Omeprazole we are giving and phenoxymethyl penicillin V for pneumococcal prophylaxis. If edema they are present, patient discomfort, furosemide we can do. Severe hypovolemia we know that dipyridamole to reduce the risk of thrombotic complication. Discuss need for heparin and warfarin with the pediatric nephrologist. Now some complication present like peritonitis present. If the patient is associated with peritonitis, then obtain the blood culture. We do peritoneal fluid culture. If possible, then start piperacillin and tazobactam, tazocin. So if peritonitis, we are giving piperacillin with tazobactam, tazocin IV, pending culture result, common organism Streptococcus pneumonia. So peritonitis we are doing culture and tazobactam we are giving piperacillin and tazobactam. Then cellulitis commonly caused by hemolytic streptococci pneumococci. Treat promptly. Thrombosis, renal vein thrombosis, an important differential in abdominal pain, cerebral vasculature, pulmonary vein, femoral vein. There is thrombocytopenia present, so rise in D-dimer and reduce PTT, ultrasound with Doppler study to look at perfusion and to image renal vein, inferior vena cava. Now what is the indication for a referral of pediatric nephrologist? So pediatric nephrologist, we know there are some cases. One is corticosteroid resistant, corticosteroid dependent and significant corticosteroid toxicity. So corticosteroid resistant when there is the disease is not responsive after 4 weeks of daily prednisolone, then we are telling, but after 3 weeks we talk with my consultant. Then corticosteroid dependent, when dependent, then 2 consecutive relapse during corticosteroid treatment or within 14 days of cessation. So if give the treatment of corticosteroid, but 2 times it is relapse occur because 14 days I stop the corticosteroid and develop. So it is corticosteroid dependent, resistant when 4 weeks given the treatment but not Responding and corticosteroid toxicity, we know that Cushing some features develop. These are age is less than 12 month, more than 12 year. Remember, 12, that is less than 1 year and more than 12 year. Then mixed nephrotic and nephritic picture, that is gross macroscopic hematuria, not microscopic hematuria. Okay. Then renal insufficiency or persistent hypertension, C3, C4, low complement level, and ANA positive, secondary nephrotic. These are the indication of refer to the nephrologist. Now I am going. How can we discharge a nephrotic syndrome patient? That is about the discharge is after with my consultant approval. Discharge once in remission, which is defined as trace or negative urine protein for 3 days. So there is negative urine protein for 3 days. Patient with normal blood pressure and stable weight. Normally twice weekly review will be required until remission, and arrange an outpatient review in 4 weeks. So when there I will discharge, I will talk with my consultant. There is urinary protein nil for 3 days. Then blood pressure normal, weight normal, edema subsided, and normally twice weekly review will be required until remissions, and then after remission review 4 weeks. New patient, what treatment we give for nephrotic syndrome? That is very important. Dose prednisolone 60 mg per meter square once daily for 4 to 6 weeks. That is maximum 80 mg, 60 mg we tell. Prednisolone 60 mg per meter square once daily for 4 to 6 weeks. Then 40 mg per meter square alternative day for 4 to 6 weeks. Gradually reduce dose, aiming to stop after 3 to 4 weeks. Response usually appear in 7 to 10 days. No response after 4 weeks. Daily steroid 60 mg per meter square suggests corticosteroid resistance. Already we know the definitions. Relapsing patient, what happened? 3 consecutive days of 3 plus or more early proteinuria having previously been in remission equal relapse. Start prednisolone 60 mg per meter square once daily, continue until nil or trace proteinuria for 3 days, then 40 mg per meter square for 4 weeks. So relapse cases, what is happened? We give start prednisone 60 mg per meter square once daily, continue until nil or trace proteinuria for 3 days. So continue will do relapse cases. Then go 40 mg per meter square for 4 weeks, gradually reduce the dose, aiming to stop after 3 weeks. If relapse frequent despite alternate day prednisolone, discuss with the pediatric nephrologist. Okay, so it is not working. Normally we are giving 4 to 6 week fast case prednisolone 60 mg per meter square. In relapse cases 60 mg per meter square we are giving until there is proteinuria nil. Remember, then we are going for alternative day. Some advice very important: carry a corticosteroid card and wear bracelet. Seek prompt medical attention for illness, especially zoster contact. Corticosteroid diary with instructions regarding corticosteroid doses. Urine testing, teach technique and provide appropriate dipstick. Test only the first urine sample of the day and keep a daily proteinuria diary and brief it to every clinic attendance. So remember the advisor: carry the corticosteroid card, steroid card, wear bracelet. When medical attention, if zoster contact, very important, corticosteroid diary maintain, proteinuria diary maintain, urine dipstick testing technique I will tell, and it will be the first urine sample. Some advice we are giving: infection precaution advice, that is avoid live vaccine for 3 months after completion of treatment with high dose of corticosteroid. So 3-month live vaccine avoid. Daily of inactivated vaccine is advisable while possible. Continue phenoxymethyl penicillin until the edema has subsided. Then if penicillin allergic, then give azithromycin. If exposure to chicken pox and zoster non-immuno, varicella zoster immunoglobulin G negative, if on high dose of corticosteroid, give IM zoster immunoglobulin, which can be given up to 10 days after exposure. If there is any sign of varicella zoster, then acyclovir IV. Varicella vaccine, live vaccine should be given if a suitable opportunity arises between the relapse. Give pneumococcal vaccine if child has not received pneumococcal conjugate vaccine. So advice we are understanding: that is avoid live vaccine 3 months. If zoster chicken pox patient, if sign, then IV acyclovir we give. If there is no sign, we give the immunoglobulin. And there is pneumococcal vaccine he will take, and varicella vaccine if get the chance, like after 3 months there is no relapse occurred, then he take the varicella vaccine. Otherwise 3 months if taking the steroid, he will not take any live vaccine. So this is all about nephrotic syndrome, video station history, everything discussions. Thank you.